Hi, my name's Anna Bonnell. I'm the nurse educator for McClure 6. Today we're going to be going through the NIH stroke scale and talking about how to perform and how to score the stroke scale that we use here, which is the modified NIH stroke scale. So first we're going to talk about the first part of this assessment, which is the level of consciousness. We at UVM for the modified assessment are only looking for alertness or not alert. So that one's pretty straightforward. We're pretty much just interacting with the patient to see if they're able to interact with us, or if not, if they seem drowsy or not alert, then we'd use a noxious stimuli to see if there's any ability to wake them up. Now we're going to also talk about best language, which is aphasia assessment. With this assessment, we're looking for whether or not the patient has either receptive or expressive aphasia or both. To do this assessment, we are interacting with them using these cards. So these cards are showing three things. One is a naming card, and this intent of this card is to provide the patient with a few items that they have to name. The items on this card are more or less difficult for an average person to recall. So that's why these items are picked here. This image is just looking for a description of the image when we ask the patient. They don't need to completely describe everything that they see, but whatever they do describe needs to make sense for the picture. And this one is for sentences. We're just looking for if they can read these sentences when we ask them to. And then the last side is the third assessment item, which is dysarthria. With the dysarthria, we are looking for the quality of their speech. So do the muscles of their mouth work appropriately for them to create normal sounding speech? These words are picked specifically because they're a little bit harder to say, and if there is dysarthria, it will be noted more easily with these words when they try to speak these words. Hi, my name's Anna. I'm going to be your nurse this afternoon. I'm going to have to do a quick stroke assessment on you, and I'm going to ask you a couple questions, okay? So first of all, what's your name?
I'm David.
Okay, great. Nice to meet you, David.
Nice to meet you.
I'm going to have you look at some cards real quick, and I just want you to name the items that you see on the card, if you can.
Okay.
Can you tell me what you see here?
Key. A cactus. A hammock. Feather. And a chair. A glove.
Okay, great. And can you tell me what you see in this picture?
I see running water and kids sneaking a cookie.
Okay, great.
Yeah.
And then, are you able to read these sentences for me?
You know how. Down to earth. I got home from work. Near the table in the dining room. They heard him speak on the radio last night.
Okay, great. Thanks so much. So for this assessment, you notice that the patient was able to do everything on the cards, although there was some kind of slowing down of his ability to read the sentences and describe the image. Some hesitancy there noted, but otherwise he was able to name everything, describe the picture, and read the sentences. So let's just talk quickly about how we would score the first two sections. So we talked about level of consciousness, first of all. With that, he was able to interact with me right away. There was no clear issue at all, so we would immediately choose 0, which is alert. With the NIH stroke scale, remember that the lower the number score, the better the patient's doing. So the higher the score, the worse they're doing. For this patient, he gets a normal score for this, which was 0. The other options on this one would be not alert, but arousable to stimulation, or not alert even with repeated stimulation, they're still not able to stay alert. So that would be a 1 and a 2, and a 3 would be a patient that is totally unresponsive, okay? With language, which was the second piece that we just assessed, he, like we said, was just a little bit, he had just some mild fluency loss with his ability to answer and describe, but he was able to do all of those things on the cards. So for him, he would get a 1, which is a mild aphasia. But if he were able to fluently talk to me with with none of that fluency loss, he would have gotten a 0, which is no aphasia at all. So a 0 and a 1 are common with NIH stroke scale, but there's also another option, 2 more options. 2 would be severe aphasia, and 3 would be globally aphasic or mute. A severely aphasic patient is going to be the patient who can't make any usable conversation with you, can't easily name a word on this paper or describe anything in a way that you can understand. Those patients usually just sound garbled, and you can't make anything meaningful out of what they're saying to you. A patient who would get a 3, which is mute or globally aphasic, is the patient who can't understand you or interact with you at all. So they're both receptive and expressively aphasic. We never want to choose a 3 unless we're absolutely sure that they can't do both of those things. So we would need to not just ask the patient to talk to us, but also give them the opportunity to write or interact non-verbally with us. If the patient can't do either of those things, and they can't understand you at all, and they don't seem to have any comprehension, that's when you can call them globally aphasic. So now we're gonna assess dysarthria for this patient. So if you could just go ahead and read me these words here.
Okay. Mama, tip top, 50-50, thanks, huckleberry, baseball player.
Great. So we were able to tell by the way he read these that he was clearly able to pronounce each of these words. So if we look at our scoring tool here for dysarthria, he would get a 0, which is normal. Some patients that aren't able to clearly pronounce the words, we would consider that some slurring of speech, would get a 1 for like a mild to moderate slurring. If the patient's speech is so unclear that you can't understand the words, then they get a 2, which is severe dysarthria. The only time they don't get a 0, 1, or 2 would be a patient that has a physical barrier, such as a trach patient who can't talk, or an intubated patient. Then there's a UN for untestable in this case. So now we're going to move on to the next piece of the assessment, which is facial palsy. With this assessment, we are looking for symmetry of the patient's face, and we're looking for any weakness or paralysis of the muscles of the face. So to perform this, I'm going to ask the patient can you go ahead and close your eyes really tight for me? Great. So when he's closing his eyes like that, I'm looking for, are both eyes able to close? Are those muscles moving equally on both sides? All right, great. Can you smile for me? So we're looking for symmetry on both sides of his face here, which is normal. And can you lift your eyebrows up for me? Great. So that looks perfect. So this patient would get a normal, which is symmetrical. If your patient can't understand what you're asking them to do, so maybe the patient has receptive aphasia and I asked and he didn't know what I was asking him to do, the best thing would be for me to pantomime what I'm looking for the patient to do. So I would do it on myself and try to get them to copy me, because that's the only way we're kind of demonstrating. So for all of these, actually, anytime the patient is receptively aphasic, try to demonstrate what you're trying to get them to do to see if they can copy you, because that's the only way they're going to learn it, because they can't understand the words that you're saying. So sometimes that's really successful with patients who are aphasic. If the patient did have some paralysis, so let's just say the average patient that we see usually has not really a full paralysis, but just some weakness of the face, therefore they have some drooping. So we see some drooping of the smile or the muscles in the face. That patient, we would just consider that asymmetrical. So the muscles still work, But when they smile and they do these muscle movements that we just showed, they're going to show asymmetry. So that patient on this scoring tool would get a 1, which is minor paralysis. And here on the scoring tool, it describes each of these for you, so you don't have to remember these. Just use this if you're not sure which item to choose. If the patient was able to do most of this except the lower part of the face didn't move, so they smiled and this whole section just stayed still, but all the rest of the muscles were moving, that would be a 2, which is a partial paralysis. And then if you find that the patient's full side of their face is not moving at all with this assessment, we would consider that a total paralysis or a complete paralysis, and they get a 3. So now we're moving on to visual assessment, which is the next piece of the NIH assessment. With this, you want to make sure that you're pretty close to the patient, within about an arm's reach, and you want to have your field of vision matching their field of vision. So if the patient can turn and look at me like this is great. If you find it's hard for them to do this or they're not doing it, you want to kind of move yourself over and get in front of the patient. So the goal is to be looking at each other and being pretty close to the patient when you perform this. So for this test, what we're looking for is we're looking at, do they have vision in the 4 quadrants of their visual field. So if you think of your eye as, each eye kind of as 4 quadrants per eye, right? So they match. We're assessing those quadrants of vision. So you're going to assess both eyes individually. So if the patient is able to use either of their hands, we would ask them to cover one of their eyes. So could you cover your right eye? Great. So I'm going to cover the matching eye to you. And the reason for this is this isn't required, but it's really helpful as you're getting used to doing this assessment. The reason for this is it allows me and you to have a similar visual field right now. So I'm going to ask you to look at my nose and don't look away, okay? Can you tell me how many fingers you see?
1.
Okay.
5. 2. 5.
Okay, great. So what we're doing there is I'm looking at kind of about approximately like a 2-foot box of vision. I don't want to be way out here because that's going to overly challenge, especially someone with baseline visual issues. You don't want to overly challenge them by making it really hard. You want to kind of stay just slightly to the outer visual field, okay? One common issue with this is the patient might tend to look at my hands as I'm assessing them. If they do that, you have to stop and start over. So if he keeps looking at my hands as I'm trying to do the numbers, you need to say, nope, look at my nose, we're going to start over and do it again. This one is a little tricky because it's hard to get used to where to have your hands while you're doing this. So a couple things to remember. You want the patient to see how many numbers you're holding up. So if I do, for example, if I turn my hand over here, so I've done this, right? I've done these first 2 fields, and then I come over here and maybe I do a 5. But right now, the 5 is facing myself. It's not facing the patient. So you want to be cautious that you're turning your hand so that they can see your hand. So I suggest that, you do kind of one field, the other, and then flip your hand over and use the back of your hand to do the other field over here, okay, so that they can see the numbers that you're holding up. Another key tip is using 1, 2, and 5s are the best options because 3s and 4s can sometimes turn into this where it just looks like, a different number, so it can be almost too challenging for the patient. So those are some just easy, quick tips on how to do this one. The other thing is don't ever forget the other eye. So now I'm going to have you cover your left eye, please. Now sometimes with most patients they might have a weak side. If they can't cover the eye themselves, there's a few things you can do. You could cover it for them, which makes it a little bit more challenging to do the assessment. So if you don't need to do that, then don't. You can also use a washcloth. You could cover this eye with a washcloth so that you're just focusing on that eye. All right, so now we're going to go to this side. All right, tell me how many numbers you see again.
1.
All right.
5.
And keep looking at my nose.
5. 2.
Okay, great. So if the patient was a little bit aphasic and wasn't able to answer 1, 2s, and 5s, for example, Another option would be just using wiggling of your fingers. So if you think they can at least respond with kind of a, yep, I see it, by maybe raising their hand, I could just say, raise your hand if you see my fingers wiggling, and I could just do this and let the person raise their hands to being able to know, see that my hands are wiggling. So again, the whole goal with this is we're looking for chunks of vision loss. So if I go through this and every time I get to here and they can't see this bottom right quadrant, then it's likely that that's where there's some vision loss going on. Now, with stroke patients, most of the time, the injury from the stroke is going to cause vision loss in both eyes in the same place. So if I do the right eye and I find that quadrant 3 is the one that had vision loss, then I'm going to expect the same thing when I assess the other eye. So they should match. The deficit should match from eye to eye in about 90% of cases with stroke. So there are a lot of other eye conditions out there where that's not true, where you can have vision issues in different ways, but for stroke it should generally match. So if it doesn't, it's a little more, maybe I need to retry the assessment. So sometimes this one takes a couple tries to get it right. So for the visual assessment, we just talked about how to perform it, but in terms of scoring it, let's just talk about that. So this patient was able to identify all 4 quadrants correctly, so that would be a 0, which is normal, no vision loss. If the patient was missing 1 quadrant of vision, we call that a partial hemianopia. So if you think hemi being half, and then it's a partial hemianopia, that's a quarter of the vision. So 1 quadrant is missing in the visual field. That would get a 1. And then if they had complete hemianopia, that means that 2 quadrants or half their visual field is missing, so they would get a 2. In rare cases, there could be a 3, which is bilateral hemianopia, meaning basically full vision loss. This is very rare and not commonly seen with strokes. If the patient has a baseline vision loss though already, like they're already blind, they still get a 3 on this, even though it's not from their stroke. So that part can be a little deceiving with the scoring, but it does count as a 3 if there's baseline vision loss. All right, so now we're moving on to the next part of the assessment, motor arm strength. With this, we're looking at the strength of the limb in completion. We're not looking at grip strength. So you always want to start with the patient's strong side. So I'm going to go ahead and ask you to hold up your arm for me. Can you hold it straight out like this? Sometimes you need to demonstrate for the patient again what you're looking for so they can copy you. Once they're holding it out, you want to start counting down from 10. Okay, so 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So with this, we're looking for any weakness that would cause the arm to not be able to maintain a straight hold for 10 seconds. So we often might see some drifting or just someone where the limb falls all the way down. In this case, he's demonstrating full strength of his arm. So then we're going to go to the other side. So if the patient is weak on this side, we can help them get to the starting point for the assessment. So I'm going to ask you to lift up that right side. Can you do that for me? Okay. Yep. Hold it straight out. If necessary, you can lift their arm up and then remove your hands and give them an attempt to hold it. Okay, so again, we're going to count down from 10. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. All right, so with this, he is a little bit weaker on the right side. So he will get a score of 1, which is drift, meaning that there's some drifting, but not to the point where it falls to the bed within the 10-second count. The other scoring options for motor arm would be 0, which is no drift at all, a 2, which is some effort against gravity. So in that case, the patient could lift and then let go and it's going to fall fairly quickly back down, but they had some ability to hold it up. And then you have no effort against gravity. That's the patient where I'm going to lift their arm and it's going to immediately fall down. They weren't able to maintain a hold at all. And then there's no movement, meaning they can't move it at all. So the difference between the one that's going to fall and no movement is that the patient whose arm falls right down, that patient can still move their fingers or hand on the bed. So even though they can't lift it, they might still be able to make some movement without gravity. Okay, so that's the distinction between a 3 and a 4, which is no movement. And then we're gonna move on to motor leg. So with motor leg, it's the same idea, except because legs are a little bit heavier, we don't expect a 10-second count. So I'm gonna hold this down for a second. And I'm gonna have you lift this leg up, and I'm gonna count to 5. 1, 2, 3, 4, 5. Great. And then we're gonna do the other side. Okay, so 5 seconds. 1, 2, 3, 4, 5. All right, so again, this side is intact with a full 5-second count, and this side has some drift but didn't fall to the bed. So same type of scoring for the legs. There would be a 1 for drift here. All right, so we're gonna move on to limb ataxia. So limb ataxia is looking at the patient's coordination of movement. So this isn't related to strength or vision or anything else, it's just how well they can coordinate the movements of their muscles. So with this, I'm gonna ask you to, if you can use your hands, I'm gonna ask you to lift up that hand and touch your nose. And I'm gonna have you reach out and touch my finger. Okay, and back to your nose, and touch my finger again, and back to your nose, and again. All right, great. So with this, what I'm looking for is whether or not the patient can extend their arm fully in a coordinated movement like this. If I'm too close to the patient, go ahead and try that again. If I go here, I'm not challenging that arm to do a coordinated movement. It's too close. And if I'm way out here, I'm over challenging a patient too much. So you want to be kind of close enough that they can do an extension and actually reach your hand. Okay, so this looks great because he can make a fluid movement here. If someone had ataxia, I would see jerky movements of their arm where they were attempting but not able to smoothly move that arm muscle. Okay, so that's what ataxia looks like with limb ataxia. All right, so don't forget, never forget the opposite side. This side was great, now we're gonna move on to that side. So go ahead and lift that arm. So again, there was a little weakness here, but you can reach, that's great. Go ahead and reach out again. Touch my hand here, okay, and back. So slow moving is not a problem with this, it's just looking at the coordination. So his coordination is still intact here, which is great. There's no jerky movements happening. So, and again, I'm just kind of moving around just to challenge him to be able to reach back and forth. So that's great. All right, and then we're gonna move down to the bottom limbs here. We're gonna look at the legs with ataxia. So for this, we call this the heel to shin. So I'm gonna have you reach this heel up onto this shin up here. And then go ahead and slide your foot all the way down your leg. Yep, and then back up. Yep. Great. So do that again. All right. So again, we're just looking for the smooth movement of the heel down the shin, which is perfect. And then again, if there's a weak side, we want to make sure that we help them start the movement. So if this was too weak for him to lift, go ahead and try to lift that leg. All right, so he's doing it, but I'm just going to kind of guide it up to the starting point, which we often have to do with patients, and go ahead and slide down and back up. All right, so this is great. He's still able to do this movement even though there's a little bit of weakness in that limb. We're just looking for coordination here, so that's great. Now, one big important thing to know about limb ataxia is that you have to see the ataxia for it to be negatively counted against the patient, meaning it has to be proven to you. You have to see it. If I can't see any ataxia, which I didn't see here, then this patient doesn't have it. If the patient is strong on the left, like this patient is, but let's say that right side was completely flaccid and he couldn't use it at all. He can't even perform this assessment at all. He can't physically do it because his weakness is so bad. That patient gets a normal score on ataxia. It seems counterintuitive because clearly the patient had a bad stroke, so you'd think he'd get a high score for this, but they don't. They actually get a normal score. So just think of this as the prove it to me step. I have to see the movement issue for it to actually be counted against the patient. With the scoring, this patient's going to get absent, which is 0, because he was able to do all 4 limbs no problem. If there was ataxia in one limb, they get a 1. If there was ataxia in 2 limbs, they would get a 2. And if there was ataxia in more than 2 limbs, which is very rare, they would still get a 2. It doesn't go higher than 2. So it's a 0, 1, or 2 on this. So one thing to note with limb ataxia is if the patient has a visual deficit, so they're blind and they can't do the finger to nose test because they can't see your finger, you can actually have them do the test without reaching to your finger by just having the patient go ahead and put your finger on your nose and just having them straighten out their hands, just reach straight out with your hand and back to your nose. So they can do it without you even being part of it. So for that patient that can't see your finger, you can do the test this way. So now we're going to move on to sensory. With the sensory assessment, we're looking for normal versus abnormal sensation on the patient. So they don't need to use any special words. They don't have to say it's numb, they don't have to say anything like that. We're just looking for, does it feel normal or does it feel different? So I'm gonna go ahead and use something sharp. Ideally, you do use a pin for this, or you could use a caliper, or this is a paper clip obviously, so this could work, but it has to really feel sharp for this to be accurate. All right, so I'm just gonna do a quick pick here. Do you feel that?
Yep.
Okay, and then I'm gonna do it on the other side. Did you feel that?
Yeah.
Did it feel the same?
Yes.
Okay. Do you feel it?
Mm-hmm.
Okay. And tell me if it feels the same or different.
Feels the same.
Okay. So then we're gonna do the upper limb and make sure you're right on the skin. Did you feel that?
Yep.
Okay.
Felt it.
Felt the same? Okay. So again, on the skin, and make sure that you're poking hard enough for them to feel it and be able to tell if there's a distinction between normal or abnormal. Then you want to go down. You can do the core of the body if you want, but you don't need to. You can go down to the legs. Never do hands and feet because baseline neuropathy can be an issue. So you would just do legs. Again, you want to be right on the skin. Did you feel that?
Yep.
Okay. And does it feel the same on this side?
Yes.
Okay, great. All right. So in terms of scoring for sensory, 0 again is normal, so this patient would get a normal. If the patient said, yeah, it feels a little different, or it feels lighter on that side, or whatever descriptor they use, but they still feel it, they would get a 1, which is a mild to moderate sensory loss. So that's going to encompass most of our patients that have some mild sensation loss from a stroke are usually going to get a 1, meaning mild to moderate. In some rare cases, you may give a 2, which is severe sensory loss. That's when the patient has no ability to feel that side at all. So they've lost complete sensation. That's rare, and we don't see it often, but if they truly lost all sensation on that side, they would get a 2. So now we're going to run through how to assess and score a patient that's comatose or not responding to any of the assessment. So level of consciousness for a patient who is comatose is obvious, they're not alert, but you would want to confirm that with a noxious stimuli to make sure they're totally unresponsive to anything you're doing. If they are totally unresponsive, they get a 3, which is the worst score for this. For language, if the patient is not interactive at all and you can't wake them up to do this assessment, so therefore I can't show them the cards, they're not going to be able to interact, then they get a 3 mute because they're not able to interact or make any attempt at language at this time. For a dysarthria patient, we are looking at, again, same issue. They can't produce speech at all because they're comatose. So this patient automatically gets a score of 2, which is severe dysarthria, even though they're not making any speech, because it also includes patients that are mute or not making any speech. Facial palsy, for the patient in this condition, we would still want to do, again, you want to do either a sternal lobe or some kind of noxious stimuli to look at their grimace of their face. So we're looking for grimace response to see if there is movement of those muscles. If we get nothing and there's no response at all, again, they're going to get the worst score, which is a 3. Visual, with visual assessment for this patient, I would open their eye. So I would open up their eye and actually try to do a threat to their eye with my hand, so just kind of a threat like that in each of the quadrants, just like we did the number assessment, but in this case it's just a visual threat to see if their eye responds by blinking at all. So this one's a little more general. We're not going to be able to tag it necessarily to a quadrant, but we're going to at least know, are they responding visually with that eye, or is there no response at all? Okay, so these patients in this condition are usually going to get a normal or the worst score, which is a 3, meaning no response. And then we move on to motor, arm and leg. Again, this patient, I'm gonna, try to lift up their limb and ask them to hold it up. We know that they're not interacting, so they're not gonna be able to do this, but we would still attempt it, at least lift up their arm, give it one try. They can't do anything, they're gonna get the worst score, which is a 4, no movement on this. Same thing with the other side. I'm gonna do the same thing with the legs. I'm gonna at least attempt. If they can't move it, they can't interact at all, they're getting the worst score on this. Limb ataxia, again, that was the one where they have to prove it to me. So this is the only one where they're not gonna get the worst score because they can't demonstrate the ataxia. So in this one, they actually get a 0, which is normal. Sensory, again, we go back to using noxious stimuli. So we go back to the pinprick, and we would still do this on the patient, and we would see if they have a grimace or any kind of response at all to me. If they do, then you could still score it. If there's no response at all, they're going to get the worst score again, in this case, which is a 2, meaning that they're not able to sense at all at this time. One thing I want to say about these patients in this condition is that, this patient might be like this right now, but if you assess them again later and they are starting to wake up or they're changing, you would still go ahead and do this assessment again as appropriate and as ordered. So we don't just assume because they were this time that they're the same at the next check. We should continue to do, or at least attempt to do, the whole assessment every time that it's due. But it is nice to know, and it makes it easier if the patient's really doing poorly and they are in this condition. You can kind of run through this pretty quickly because they can't actually do a lot of the assessment. So you're automatically going to have a score that you can choose. One thing I want to mention though about this scoring is that you should always score it. You should never use the UN untestable unless it actually applies. So just because they're not awake doesn't mean you don't give them a score. So again, they do still get a score even if they're in this condition.